All right, people, welcome back to One Body. I'm Cruzy.
I'm Eden.
Today we are joined by Dr. McLelland. We are so lucky to have you. So Dr. McLelland is a board certified OB/GYN. Our families know each other. We're all from
Mhm.
Chattanooga, which is a fun connection. Eden and Dr. McLelland both are now back in Chattanooga after both living in various places. So today we're going to be talking about PCOS, which is polycystic ovary syndrome. And it's a very, very important topic. I'm really excited to pick your brain. First, I would love if you could just tell us a little bit about yourself. Tell us what your medical training was, how you got to where you are now, and then what you're currently doing right now.
Well, first of all, thank you for having me. This is really exciting. The whole reason I became an OBGYN was to empower women to greater health. And I love doing it one-on-one, but it is also so wonderful to be able to cast a wider net and have people curious and hearing new things to help them just feel better. I went to Vanderbilt for undergrad and for medical school, and I did my residency in OBGYN at Emory. I spent a couple years in Atlanta and quickly realized that that was not where I wanted to be. Sorry.
No shade.
Um, at the time, and still, but at the time, really, all the things I enjoyed doing were outside. So mountain biking and whitewater kayaking were my passion, and hiking. And you could do that in Atlanta, but you always had to travel. And then I moved to Portland, Oregon, and Portland, Oregon was an absolutely wonderful place for me. I joined a fabulous group. I was there for about 4.5, 5 years. One of the things that was wonderful when I was out there was, first of all, the level of commitment for healthy lifestyles.
Mm.
And what goes on with that is the demand for healthier foods. So
Wow.
I'll never forget when I went to Fred Meyer, which is a grocery store kind of like Walmart. And the first time I walked in there, they had this huge organic section. Things were not wrapped in plastic. They had local produce there.
Mhm.
And yes, there were definitely nicer supermarkets, but you could go to a very basic one and get that. And this is also about 25 years ago.
Mhm.
So we're not talking about yesterday. We're talking about 25 years ago. And everybody was active. So that was very empowering to me because before I moved to Portland, when I would talk to people about healthy lifestyles, I couldn't get anywhere. And, it was like, oh, yeah,
Mhm.
that's good for somebody. So the basic level of health was absolutely wonderful. The other thing that was really a key to my journey, because one of the things that I've really focused on in the last 5, 10 years is more of a functional medicine approach and integrative approach. And a lot of these seeds of this was when I was in Portland, Oregon. So another thing was there were some really well-known, actually world-renowned naturopaths in Portland. So there was a really neat community that collaborated very well with physicians. So 25 years ago, naturopaths and physicians may not have been very collaborative.
Mhm.
And I definitely know that in other areas, but in Portland, it wasn't like that. And there was one time, and it was actually a patient with PCOS, where I just picked up the phone and called this woman who was a very well-known naturopath and said, listen, I want to learn more. I feel like the medical approach for PCOS is very limited. We're just band-aiding the problem and we're not really addressing root causes.
Mm.
And I would like to know a little bit more. Now, of course, her focus was botanicals. And I said, I've got a pretty good sense on the rest, but I really am limited on understanding of the botanical component.
Mhm.
And she was fabulous. She was wonderful. She was super helpful. She gave me some good information, resources. So that was a really wonderful collaborative approach. And to my point that I made earlier, I started looking more into functional medicine and integrative approach. And the reason why is just giving somebody a pill does not fix everything. There's amazing things in my skill set as a general OBGYN, but I just wanted more tools. So I wanted to be able to tell somebody not just eat healthier, but in your situation, with the tools you have, with what you want to do, here is a plan for you.
Mhm.
And it just gave so many more amazing tools. And one of the things that I agree with fundamentally, which is the integrative approach, is food is medicine.
Yeah.
Mm.
And what was interesting is when I moved back here, when I talked to people, and this has changed, okay, somewhat, but when I came here and moved back to Chattanooga and I was so excited about having all these tools, people would ask me for a natural approach. And what they really meant was they didn't want medication prescriptions, but they wanted supplements. And I definitely utilize supplements and botanicals, but I'm not going to put somebody on 20 prescription medications, which means I'm also not going to put you on 20 of something else.
Yeah.
Mhm.
So I still think that food is medicine, and the focus on nutrition and exercise is so incredibly important.
Mm-hmm. Well, props to you for being collaborative with the naturopaths 25 years ago, you said. I mean,
Yes.
I think even today still you see some pushback
Mhm.
from conventionally trained physicians or providers to anyone outside of that. So, I think it is changing. I think people are realizing like what purely conventional medicine has to offer sometimes is not cutting it. A lot of times people try to go seek other sources. So props to you for being collaborative in that way. And then you went to, you got some training from IFM, Institute for Functional Medicine. Was
Yes,
that?
I started with that, and then I ended up doing a integrative course with Aviva Ram, and she's amazing. And what I love about her, do you know anything about her?
I've seen that name, but I haven't looked
Okay.
into any of her work.
Yeah, she has a fascinating background. She started out as a lay midwife and a naturopath. And she got to a certain point where she realized that her influence was not what she wanted it to be, and that she needed to go the conventional route to
Mhm.
really
Mhm.
break into just being somebody paying attention to her across the United States. And she went to Yale Medical School. And what I love about her is she really does practice evidence based medicine. And what evidence based means is you look at the knowledge, you look at studies, and you look at the goals and values of the individual.
Mhm.
So, one of the challenges with conventional medicine is people talk about randomized controlled clinical trials as basically being the coup de grace, the
Mhm.
it study. The problem is those are so narrow that when you apply them to everyday life, then it's really challenging
Mhm.
because all of the variables are so narrowed down. You know, you look at Chinese medicine where you don't have these randomized controlled trials, but you have thousands of years of accumulated wisdom,
Mhm.
and you can't discount that.
Mhm.
And so that's what I love is I really, and that's one of the reasons why I took that course, is because it was very obvious that she looked at all of those areas.
Hmm. Even a randomized control trial with a drug, with a medical drug, would be applicable to someone who's similar to what the study was, the participants in the
Right,
study taking that one drug. But as you know, I mean, most people in America who are on one drug are also on five others. So it's like,
right,
who knows how those five drugs interact?
Mhm.
So even
right.
evidence-based medicine in the very conventional, like strictest way isn't necessarily what's actually going to happen in real life. So yeah, I like how you're kind of seeing that it can be broader than that very strict,
Mhm.
Right.
only what's been studied in that specific way.
Well, it's interesting because, to your point, a randomized controlled trial is looking at one medicine, and then you're not allowed to be on a bunch of medicines because that'll confuse it.
Yeah.
Mhm.
And another common thing with randomized controlled trials historically is a lot of times BMI is limited. So you have a
Mhm.
very narrow BMI or weight And that's not going to apply because we know that medicines behave differently based on your BMI.
Mhm.
Not all medicines, but a lot of medicines. So if you look at number of medicines somebody's on and somebody's BMI, you're not going to be able to tell somebody exactly. So, somebody will ask me, well, what is this medicine going to do to me? And I'm like, yeah, I don't know.
Yeah.
I can tell you what it might do if you're
Mhm.
on one medicine,
Yeah.
but I can't tell you exactly what's going to happen with you being on 5 or 6.
Mhm.
And that was such a huge driver for me to try to figure out ways not to add medications and to improve somebody's overall quality of life.
Right.
And and sometimes you do need medicines. And sometimes surgery is a game changer. And so that's what I love about having all of those at my fingertips. And really, the 6 pillars of health when you're looking at through the integrative lens is diet, exercise, restorative sleep, stress management, botanicals and supplements, and then medical therapies.
Mm.
So you look at all of those.
Yeah.
That's really helpful. I don't think I've heard that before. And I think what I'm seeing right now is sort of these two extremes of sort of ditching Western medicine and just not even considering that, only going supernatural, or the other side of the spectrum that's just totally closed off to any other consideration. So we appreciate your dedication to be a
Yes.
collaborator without sacrificing like the evidence piece of it, because that's necessary.
And
Um,
I think it's, what I love to describe it as, now I have more tools to help you dip your toe into
mhm,
that stream of health. So, I'll ask somebody, what are your goals? And then we'll go through those 6 different pillars and say, where do you want to go? So I could
mm,
have 3 women in a row with the exact same health issue, but their goals are different. So we have a different personalized plan.
Yeah.
mhm. And goals that need to be realistic for that time and that person. I feel like that's a question I ask a lot. What is realistic for you? Because
Yeah.
this might be
Yeah.
realistic for me, but maybe not for you right now. I like it. Okay, tell us. It sounds like you love your job. Like you are
Yes, I
passionate
do.
about what you do. You are good at
Yes.
what you do. Tell us if you had to pick, like, what is your favorite part of your job currently in this year?
So, can I say it's a two-parter?
Yes.
Okay. Um, Probably, one of my favorite part is really hormone health.
Hmm.
Really hormone health. And when it comes to hormone health, that kind of spans a woman's lifestyle or a lifespan. But the ones that I really am passionate about are PMS, PCOS, but primarily midlife, perimenopause, menopause. And really, what I love about those 3 is that's where I feel like I can help people the most.
Mm.
But every tool that I need to address those are tools that I use everywhere else. The other thing I love about that is it's really a collaboration. I'm not fixing anybody in those areas.
Mm.
You and I are fixing together, but also you have to figure out how to help somebody get somewhere. And I can't just make somebody. I can't just say, "Oh,
Mhm.
do this and you're going to feel better." They have to buy into it. Buy into it. So I love that part. I also really enjoy operating, but the combination, and I love how the surgery fits into that. So
Uh,
if somebody, for instance, has endometriosis, I saw somebody last week. She had a successful surgery for endometriosis. She has now, her quality of life, because she is not having pain, has so dramatically improved that now we can talk about the lifestyle
Mm.
changes
Yeah.
to help minimize recurrence and improve pregnancy. So she would not have had that improvement in quality of life without that surgery.
Yeah.
Right.
Uh, so, so I love those are probably my top favorite.
I
Yeah.
like it. Have you always enjoyed the OR?
Yes,
Yeah.
I've always enjoyed the OR. The body is so amazing and
Mhm.
so fascinating, and it is so humbling to look inside of somebody's abdomen.
Yeah.
Mhm.
I mean, it is just so amazing. So it's humbling every time. I mean, I don't think of it like that every single time, but it's awe-inspiring.
Yeah, it
Yeah.
is. And I mean, to me, as someone who is a Christian and believes like we were created, is fascinating to learn about anatomy and then to be able to see it, in real life, either in a cadaver or in the OR and be like, wow,
Mhm.
this is amazing how all these organs are functioning and how they're
I
all
know.
talking to each other and how things
Mhm.
aren't like how we can even live is wild. So I'm with you.
I know.
Yeah. Okay. I
Mhm.
think let's jump into PCOS before we just end up taking all of your time today. Okay, so just very baseline, tell us what is PCOS?
So PCOS, there's a criteria called the Rotterdam criteria to diagnose PCOS. And basically, it's a combination of two of the three following criteria. One is irregular periods. The other is evidence of too much testosterone, either clinically because of acne, male pattern hair growth like facial hair, hair thinning. So the most common in this scenario would be thinning of your part, widening of the part. So those would be evidence of too much testosterone. And then the last criteria is multiple cysts on the ovaries. Since it's two out of the three of those, then you could have 10 women with PCOS in the room, and they all look a little bit different. Classically, though, women with PCOS are often overweight or obese and oftentimes have insulin resistance or prediabetes as well. So, and it's considered a clinical diagnosis, meaning
Mhm.
you don't need most of the time you don't need the lab work or the ultrasound to diagnose it. So you can walk in and you can tell that somebody has PCOS. And now the caveat to that is that a lot of women with PCOS have done something for hair growth. And so you may not be able to see that immediately because they plucked yesterday or they're
Mhm.
doing laser hair removal. What's so amazing about PCOS is it really can impact almost every important part of your life. On the fertility side, the women's health side, you have issues with fertility. You have a higher rate of miscarriage. Because the hormonal changes, you have too much estrogen, too much testosterone, not enough progesterone. That also increases your risk for uterine cancer or precancerous changes. Oftentimes, women will have heavy, irregular periods. So they don't have their periods very often, but when they do, they're really heavy and very difficult to manage. So that's kind of an overview of the women's health issues. So I've been practicing for 27 years, and it used to bug me that we only focused on the women's health part of it
Mhm.
because there's so many metabolic issues that can be occurring as well, which is really going to impact the trajectory of somebody's life,
Mhm.
right? So PCOS is okay, maybe it's not an issue after you go through menopause, but you have all the metabolic issues still present. So for women with PCOS, they have a higher risk for sleep apnea, higher risk for obesity, diabetes, insulin resistance, elevated cholesterol, where you see high triglycerides, high LDL, and low HDL
Mhm.
cholesterol. You also see a higher rate of what's called fatty liver. And you also are seeing a higher rate of mood disorders, anxiety, depression. You're also seeing a higher rate of eating disorders,
Mhm.
mostly binge eating. So, all of these other factors, even if you take the specific women's health issues out of it, the rest of these factors really impact the trajectory of somebody's quality of life.
Mhm.
And when you think about treatment and you think about the typical medical approach with medications, is I just didn't feel like I saw people thriving.
Mhm.
Some would. But the most common was, okay, I've given you about 5 or 6 different Band-Aids, and I watched this woman just kind of hobble along.
Mhm.
Mm.
So those are some of the main health issues. And I think it's super important to assess all of that. And it can be overwhelming, and you may not do that in one visit, but it's super important to help. And, it's different. A 31-year-old who diagnosed with PCOS is able to start to assimilate that with one visit. You have a 17-year-old who is depressed because they have terrible acne, they have facial hair, they've gained weight, they're just
Mm-hmm.
they want to cry, they just don't want to be seen. To try to help them get beyond, like, oh my goodness, look at all these health risks. You're not going to pile all that on their first visit. That would be, you got to really look at, okay, what is bothering you the most right now? And then we'll work on adjusting the trajectory here. So how you approach PCOS is really different for every individual. So last week, I had back-to-back PCOS patients, one who was a teenager who had no interest in lifestyle stuff, like even to the point of getting mad at me for asking her about nutrition and turning to her mother saying, I told you if she talked about this, I wasn't coming back.
Oh.
I was like, okay.
Mm-hmm.
So somebody overweight, well, actually obese,
Mm.
depressed, no motivation for making any changes, mortified by her acne and facial hair. And the irregular period. So for her, we started out with birth control pills. She had insulin resistance. So over the course of 6 months, she and her mom opted for birth control pills, spironolactone, which is an anti-testosterone medication, as well as metformin, which is for insulin resistance. Her skin cleared up, her hair growth improved along with laser hair removal. What's interesting in my experience, a lot of women, once you improve those incredibly bothersome symptoms, then they feel better and they want to continue to feel even better. And then they will incorporate the lifestyle. But then my next patient with PCOS was somebody who had longstanding infertility. She had one more embryo to place. She was in her early 30s, and she said, I want to reassess everything with PCOS, and I want to give myself 6 months to lose 20 pounds. And so I'm healthier when the next embryo is placed. So she had one successful embryo, the second one miscarried, and this was her last embryo.
Wow.
And so for her, our focus was on the lifestyle. Fortunately for her, she was able to she was able to see a dietitian, had a personal trainer. So it was still PCOS, but you had completely different focus on quality of life. The last time I saw her, her quality of life was so dramatically improved by losing that weight and just overall eating healthier and exercising. And that's really the goal. Is I think sometimes we trip ourselves up by thinking of, okay, we have to get here, when really it's every day being healthier.
Yeah.
Every day is a series of thousands and thousands of choices. And it is really just as easy to make this little choice as in this little choice. But when you're a mile down the road, that's a huge change.
Yeah. Agreed. So, okay, just to make sure we all are on the same page, diagnosis would be 2 out of the 3, either irregular periods, signs of excess testosterone, which could be clinically what you see, or do you ever test like
Oh
the
yeah, lab work.
labs?
I'm going to always test lab work, even if I can tell that, somebody has significant acne or facial hair. Even though the most common diagnosis with elevated testosterone is going to be PCOS, there are other very rare things that you want to rule out pretty quickly.
Makes sense. Okay. So those 2, and then if you see excess cysts on the ultrasound on the ovaries.
Correct.
2 of those 3. I'm curious why, and from my perspective, I know probably 10 people with PCOS, and I know currently is it about 9 to 13%, around 10% of females of reproductive age have PCOS. Is that what the stat you agree
Yeah,
with?
that's true. Yeah.
So to me, that feels crazy. That feels like it's really increasing in prevalence. Would you say
Mm.
that's true? And if so, maybe that's just associated with our poor lifestyle and metabolic health? Or is it more of just an increase in awareness that more people are being diagnosed with it because more people are aware to even think about it as an issue?
I think it's more related to our underlying health. I
Oh,
mean, if you look at it, if you look at the rate of obesity increasing in the United States in the last 30 years, that rate has just skyrocketed.
yeah.
And as you gain weight, you become more insulin resistant. And
Mhm.
so there's two things. We don't know exactly what causes PCOS, but two of the most important underlying factors are hormone imbalance as well as insulin resistance, blood sugar balance. Other things would be inflammation, gut health, stress. Those would be some of the main root causes. And if you think about it, if you just correlate it with weight gain, every single one of our fat cells produces a very weak estrogen. And
Mm.
so eventually, as that as that increases, you are going to kind of knock off balance with the normal ovarian hormone production because of the other estrogen there, as well as the testosterone. But as you gain weight, you are increasing your whole body inflammation. You are also becoming more insulin resistant. So
Mhm.
you may not have lab work that says you're diabetic or you're significant insulin resistant. You still have insulin resistance. So even if the only thing is weight gain, that would be enough to explain the increased PCOS. Then you also look at our food being less nutritious. And when you have so much processed foods, you're increasing insulin resistance, you're increasing inflammation, but you're also reducing healthy nutrients.
Yeah.
So you get this picture of overfed and undernourished.
Hmm.
Mm.
So here's a fun data point. What percent of Americans get the recommended amount of fruits and vegetables a day?
Oh, gosh.
Low, low, low. 20.
15%.
15.
15%.
Wow.
Yeah.
And it's like and don't quote me exactly on this number, but for like teenage women who get enough calcium and vitamin D, it may be about 10%.
Wow.
Yeah. And that could all be
Uh,
like, we should be able to hit those targets with our food. I mean, I know like the actual food itself is now more depleted because of farming practices and things, but we should be consuming enough nutritious foods, ideally. There's tons of factors, including access, but it's just sad to think we're missing the mark that badly. And yet we're still
well,
so overweight because the food we are consuming lacks so much nutrition. It's so crazy.
Well, I think a couple things. First of all, there are many instances where healthy food, what we consider healthiest, where there's definitely limitations.
Mhm.
But almost any grocery store you go to, you can make healthier choices.
Mhm.
And what you have is you have nutritious foods. And then have you heard of the term frankenfoods?
Mm-mm.
Oh, I love this term. Frankenfoods are basically processed foods that there's nothing in it that your body's going
Mhm.
to recognize as normal. And there's plenty of foods that I would call it an anti-food. So it's not just that you're not getting nutrition, but you're blocking nutrition.
Hmm.
Yeah.
I mean, look at the amount of sodas people are drinking,
Mhm.
Mhm.
the high calorie sugary drinks. That's anti. So
Yeah.
so I think it's important. It's not so you can eat healthy food. I'm sure there's some food out there that's kind of just neutral. I'm not sure
Mhm.
what that is. Then all the processed food is anti.
Yeah.
Mm.
Wreaking havoc on your gut and everything else. So, yeah.
But one of the problems with this is that our bodies are so amazing. They're so beautiful. They are, you know, they're a temple. What goes along with that too is our bodies are incredibly resilient.
Mhm.
And in some ways that's good, and some ways it's not.
Yeah.
So for instance, if you put water in your gas tank of your car immediately would not drive. It would
Right.
lock up. I've never tried it, but I think it would lock up immediately. Whereas I will see women who are starting to have symptoms. Let's say they're not feeling well and they're in their 40s and they're like, well, I haven't changed anything. And it's like, you're right, because your bodies are so resilient that you could do this for 20 years. You could eat that unhealthy for 20
Mhm.
years and your body is not going to give you symptoms. And so it would probably be good if people felt bad when they ate something unhealthy.
Mhm.
That would be a really good feedback loop.
Well, it's just interesting to hear how much like nutrition and weight in general plays a part of PCOS. I feel like all of the women I know currently are, it seems like their nutrition is top notch. They're very fit young women. So maybe it can feel frustrating or confusing for those women to feel like I'm doing so many of these things, but they're
I
still
think
missing puzzle pieces.
I think that's a very important point because there is a higher rate of what we call thin PCOS. And metabolically, it's got to be different, but we don't have the best answers for that.
Mhm.
I still think that there's, the nutritious eating. And the other thing to remember too is that when we use the word healthy eating, we don't really know exactly what that means.
Right.
Okay. So a lot of people will tell me that they eat really healthy, and when I review their food diaries, I would not use that term, and I would definitely not say that it is hormone healthy.
Mhm.
Okay. So I'll give you an example. A common thing that I'll see is using when you talk about the amount of protein you need to eat, it's hard to get enough protein. And so people will supplement protein. And then I'll see a lot of soy products used as protein sources. Well, soy products, the way soy is processed in the United States is not very healthy. And if you are primarily getting processed soy as your protein source, it's still processed and
Mm.
it's not as recognizable as if you just ate some beans. If your preference is to avoid meat, then if you just eat beans
Mhm.
or whatever. So there's a lot of foods that are given, and this is another term I love, is a health halo,
Mm.
right? Oh, that's healthy because I got it at this, health food store.
Or it's gluten
Well,
free or something like
it's
that.
still processed,
Yeah.
right? The best, what the best gluten-free diet is, and I eat meat, so is meat, veggies, and fruit.
Hmm.
Right.
That's a gluten-free diet,
Right.
Mhm.
you know? And so I think that I try to stay away from words like healthy
Mhm.
because that gives people attach shame
Mhm.
to that. And then the moment somebody feels ashamed, they've kind of blocked their ability to be creative. Now I can't control that, right? But I can sure be a little bit better about my choices of terms when I'm reviewing food diaries of women struggling with different health issues. Almost everyone can make adjustments, and not everybody. I totally believe that, but there's usually most people can make some adjustments. Unfortunately, it's not always going to move the needle
Mm.
for them.
Mhm.
So when you see someone, it's similar to what Eden was asking, but it is interesting because I'm thinking of about three of my friends who I think of very healthy. Again, it's a hard term to really clarify, but they have PCOS, BMI perfectly healthy, their lifestyle, at least from the outside and from what I've picked up on, they really prioritize those pillars of health that you were talking about. and they eat well, they fuel their body well, they exercise, they sleep well, et cetera, et cetera. They have PCOS. And to me, I'm just interested, like when you see a patient in that way, are the other factors that can cause PCOS that maybe we don't understand as well? Are those just more at play in that situation versus the metabolic dysfunction and the insulin resistance? Or is it just harder to explain why they ended up with PCOS?
I think it's harder to explain.
Okay.
It's definitely harder to explain. I think there's still going to be a hormone balance and there's going to be a metabolic issue, but it's not one that we can easily explain.
Hmm.
And then when we think about our 6 pillars of health, diet, exercise, sleep, stress management, supplements and medications, you could really do a very good job of looking at your diet and your exercise, and still you haven't moved the needle very much. And then when I say move the needle, then it kind of is what's going on, right? So that young lady who has irregular periods and is trying to get pregnant, and she is really healthy. She's doing exactly what I've told her to do. And her periods are still 3 times a year. Well, I'm sorry, I don't know what else to
Mm-hmm.
do. And I can give you medications to make you ovulate,
Yeah. Makes sense.
right?
Yeah.
So you look at all 6 of those areas. So even as you improve somebody's insulin resistance, I don't have a good answer for why somebody with PCOS has a harder time losing weight
Hmm.
than somebody who doesn't. So I would say, if women are really trying to move the needle, there there is definitely benefit from medications. And so, if you think about it, looking at it from the conventional point of view, if somebody has irregular periods, then irregular heavy periods, first of all, it's annoying and it's frustrating and aggravating. Plus, that increases your risk for uterine cancer. I definitely have had patients that, even with all the healthy aspects, they're still having irregular heavy periods. And so, then you're looking at birth control pills, a Mirena IUD, different progesterone options, because no matter what we've done for them, we still haven't reduced their heavy periods and their risk for uterine cancer.
Mm-hmm.
Hmm.
And then you have the patient who I mentioned earlier who still needs help ovulating. And also there's a time frame there too, right? So if you really want to get pregnant, if you want to try a supplement that may take 6 months to a year to see a change.
Mm-hmm.
Maybe if you're 21, you don't care, but if you
Right.
are 33 or 34, it's like, yeah, not so much.
And
Mm-hmm.
a lot of people
Um,
aren't diagnosed with PCOS until they're in their 30s and they've been trying to get pregnant, and it's the first time
right.
they're really sitting down with their gynecologist or their OB and saying, what's going on? Because a lot of times the symptoms of PCOS can kind of be, let's say someone's been on oral birth control pills since they were 15 and now they're 30 and they're trying to get pregnant for the first time. They may only just now be realizing that they have this picture. So
Mm-hmm.
that's kind of
Yeah.
the frustrating part, because then time is ticking for some people, it's like we really need to hit these things head on and not dilly-dally.
Okay, this is a quick interruption here because I realized we talked about this offline and it wasn't being recorded, and it's one of my favorite parts of the episode is talking about the specific supplements and botanicals, which is just plant-based supplements that are really helpful for people with PCOS and the ones that Dr. McLelland uses. So she told us that in regards to supplements for general support for someone with PCOS, she recommends vitamin D, B12, omega-3 fatty acids, and then typically also a multivitamin just to cover any nutritional gaps. And then for someone with insulin resistance, if you don't want to be on metformin, which again is the medication that's used for improving insulin resistance, there is a supplement called inositol, and it has the best evidence for improving that. And then there's also some benefits from a supplement called berberine, but typically inositol is what's reached for first. If someone has irregular periods and they don't want to be on oral birth control pills, then there's an adaptogen called chasteberry that she recommends. So just to go into a little bit of detail on those, inositol, like we said, it's the one that is helpful for insulin regulation. So it's a natural sugar, and it's really helpful for cell structure, for insulin signaling. So it helps cells respond effectively to insulin, which is important for blood sugar control. And then it's also helpful for reproductive health. So it plays a role in ovarian function and egg quality, and specifically in women with PCOS. So the body actually produces most of the inositol it needs from the kidneys and the liver, and it's found naturally in a lot of foods: fruits, beans, other legumes, whole grains, brown rice, nuts and seeds, but you can get a lot more in a supplement. And again, a lot of us are not actually getting the nutrients we need from our food, and so it can be helpful for that. There's a lot of different brands now that have some sort of inositol supplement, but the ones that I have looked thoroughly at and have heard of friends taking and being prescribed by functional medicine practitioners or by their OB, one is from Thorne, which I've talked about before. They have a supplement called Ovarian Care, and it has folate, it has inositol, it has CoQ10, which is very helpful, wild berry complex, green tea extract, and a pomegranate extract. So that is a great one. That's a powder. Thorne also has one called Hormone Advantage, which is DIM, D-I-M, with pomegranate and broccoli extract. So this one's a capsule. So it has DIM, pomegranate extract, and then broccoli extract. So this one is a pill, and it's very helpful for just hormone balancing. Helps to balance your testosterone and your progesterone levels. Then there's one from Parallel, Perellel, which is a popular prenatal and women's health brand. They have one called Hormonal Balance Support. This one has inositol, it has berberine and alpha lipoic acid and DIM. So this one's helpful for anyone with PCOS. A lot of the comments say like it helped to regulate their cycles and they just felt more balanced. And I do trust that brand. It's founded by an OBGYN. Then we talked about berberine. So this is also similar to inositol. It's a natural chemical. It's found in roots, stems, and the barks of various plants. So it's going to help the body activate an enzyme. It's called AMP kinase, and it's like the metabolic activator in the body. So it helps with a lot. It helps with blood sugar control, cholesterol, heart health, weight management. It helps in PCOS to improve metabolic and endocrine health by lowering the blood sugar and the testosterone levels, and then also can help with the gut health. And then she said the adaptogen chasteberry, which an adaptogen is just a natural supplement. It's from like an herb, a root, a mushroom. It helps the body resist and recover from stress on the body and then restore balance. So it's building resilience. So chasteberry, it's also known as Vitex, Vitex. It's a berry from a shrub, and it's really helpful for women's hormone health with like PMS, menstrual irregularities, and then it helps balance the progesterone and the estrogen and prolactin. So it can be helpful for some for improving fertility. It can help with acne and with PMS symptoms. So again, anytime you are thinking about starting a supplement, talk to your provider. They come with side effects as well, and it's important to know before you just start taking one. And also pay close attention to your body once you start any new medicine or supplement to make sure that you're not having bad side effects that could be related to it. So, okay, now back to the rest of the episode. I just had to put this in there.
And some of the medications that are really helpful, like oral birth control pills, spironolactone, metformin, for that kind of picture of someone who is not trying to get pregnant, has the insulin resistance, that seems to work very well in that stage. Can you talk a bit about, one, why infertility is an issue in this case, and then how you manage that?
So the main reason for infertility is that you're just not ovulating. Either you're not ovulating at all or it's very unpredictable and irregular. So if you're having regular periods, you're ovulating predictably 12 or 13 times a year. If you have PCOS and you're not ovulating, it's fewer times and very unpredictable.
Mhm.
And so, sometimes you make the lifestyle changes and you see an improvement, but you don't always. And so if a woman only has ovulatory dysfunction and we've ruled out issues like tubes are closed or male factor or something like that, then we do ovulation induction. And there's two main medications. One of them is letrozole, or also called Femara, and the other one is Clomid. We don't use Clomid as much anymore because there's been some really good studies that have shown that letrozole works better in this, and there is lower multiple rates. And so for the most part, most people are going to start out with letrozole. Now, there are times where Clomid does help, but that's the mainstay is ovulation induction. And that's totally within my wheelhouse. If there is a male factor, or if somebody's tubes are blocked, or if there's a scenario where IVF is the right answer, that's not in my wheelhouse, and I refer on to reproductive endocrinologist.
Is there a general success rate that you tell patients when using a ovulation induction, or is it just totally depends on their situation?
Well, it totally depends on their situation. Most women are going to get pregnant within 3 to 7 cycles of an ovulation induction
Okay.
once they're ovulating. So usually I like to kind of regroup at 3 or 4 if they haven't been successful. Some women will opt to continue, but when I tell women when I'm helping them get pregnant, I have 2 goals. One of them is the obvious goal, and that is helping you get pregnant. But the second one is just as important, is I don't want to waste your time.
Yeah.
So if I have a sense that this is not really going to work, or it hasn't worked as quickly as I expected, I want you to choose that you want to continue it. I don't want my lack of counsel be the reason why you choose to continue. But of course, having said that, you've done a full evaluation for primary infertility before you have that discussion.
Was there anything else in the management world that you wanted to touch on? I feel like you went over most of it, but just in case.
So what are your questions about the GLPs?
Yeah, well, that was actually my next question was, are you incorporating those into your practice? Have those been studied with PCOS, or is it too new?
So it hasn't been studied well enough in PCOS, but it's a treatment for type 2 diabetes, which is is part of the insulin resistant picture. So what's really fascinating and what I've seen for women with PCOS is there's several things. One of them is the insulin resistance. The other is the inflammation.
Mm.
So what's fascinating about the GLPs, as they're being used more, people are recognizing that it's helpful for other things. So one of the things that I have seen is women who have either diagnosed arthritis or generalized joint aches, pains. The amount of reduction in pain that I see does not make sense that it's only weight.
Mm.
If that makes sense, is like, okay, there's more of an inflammatory picture. There's more on the benefit of inflammation. And so the things that I see the most with the GLPs in this scenario, first of all, it's really hard to lose weight just by doing the lifestyle changes in PCOS. And it's harder in PCOS than it is in somebody without. And you have to acknowledge that. And acknowledge it in a way that's empowering, not like, okay, this is never, the lifestyle is not going to work for you. But it is empowering for somebody to tell you that something's not going to work,
Yeah. Well, tell them it's not their fault. It's not that they're not trying
right?
hard enough. It's that actually the way their body is functioning right now is kind of fighting against weight loss. So,
Right. And so let's just acknowledge that, we have to do this, of course, but it's just not going to work as well. And so I see better weight loss. You see this reduction in inflammation and joint aches, etc. You're also seeing a reduction in some of these other health issues related, like the cholesterol issues, insulin resistance, sleep apnea. And anytime you move the needle on those things, that also helps with weight loss. But another thing that I see too is a reduction in this food noise. And people describe that as different, but it's less, it's not just about a craving, like all of a sudden, oh my goodness, I really want to eat 20 Oreos. It's not even that. It's this constant thinking about food that just all of a sudden kind of quiets down and goes into the background. And so when somebody sits down, they are like, am I hungry or am I not hungry? So the normal satiety and hunger hormones, ghrelin and leptin, they're actually doing what they're supposed to do. Oh yeah, you're hungry. Okay, I'll eat. Oh no, you're full now. Okay, I'll stop. And that is an incredibly common thing that women will notice. And it's amazing how women will describe that as so freeing.
Yeah.
To lose that noise. And that's what's fascinating as well. Now, the downside, there's always downsides to everything, right? So the downsides to the GLPs is you don't want to lose too quickly because you are losing more lean muscle mass.
Yeah.
And so if somebody were to start a GLP, my preference would be that they would start first a diet and exercise plan for X amount of time where they're really figuring out a strength training program and they're figuring out how to get enough protein. And there's different recommendations for protein, but typically, if you want to take protein in and really help build muscle, you need probably about 25 to 35 grams per meal. What I like to do, ideally, I would like to have somebody do a food diary. We figure out how much protein and then figure out how to get more protein in every meal. So if our first goal is 60 grams a day, but you should be getting 100, that's fine. Let's start there and kind of figure that out. And it would be ideal if somebody could be doing a strength program 2 times a week. The problem is, and there's plenty of data to show this, is that women who go off GLPs acutely, they regain all their weight very quickly. Have you seen that?
Yeah.
Have you seen that? Have you noticed that it's far quicker than you would anticipate?
I mean, yeah, I think it's concerning because especially a lot of people will also incorporate a lot of the lifestyle changes in once they're on a GLP-1 agonist, but then yeah, if they get off, it comes back. And it's concerning. I don't know what your take is on how long you want people on these injections, but does this mean that someone needs to be on it for forever? Or does it just mean they came off too quickly or they weren't ready yet? Their body needed more time on it.
So, we're figuring all this out. Unfortunately, I think that one of the things that's recommended is to be on it for life. And I really think that the focus should be more on how do we help get somebody off of it and still maintain that weight loss. One area where we're seeing people acutely stopping the GLPs is pregnancy. The recommendation is to stop a GLP 3 months before pregnancy. And it's more about we don't really know than I have all this bad data. And so what we're seeing is we're seeing women, in my experience, I don't have patients stopping it 3 months before they get pregnant. I have them stopping it when they find out they're pregnant. And what's interesting, some preliminary data, even if they've lost weight, they actually have a higher rate for gestational diabetes, preeclampsia, all of the things that we're trying to reduce by helping somebody lose weight. So actually, these women who are preliminary data, there's been a couple studies, and the studies were good enough for me to kind of say, whoa, let's pause for a second. If you have PCOS, you're insulin resistant, all of these risks in pregnancy. It makes sense that I'm going to lose weight, but for some reason, the GLPs are not preventing that. And actually, the risk is higher. So you don't really know why. Is it because these women lose the weight and then they gain so rapidly? It's really sad to see the weight gain that I see in pregnancy in somebody who has acutely stopped a GLP.
Yeah.
Uh,
Yeah.
It's ridiculously rapid. And so it is a game changer for women in this population. But with this recent data on GLPs and pregnancy, that's a harder conversation to kind of figure out how that plays into it if fertility is part of your goal. You know, what's interesting is a lot of the data on mortality benefits of GLP is related to data in people with type 2 diabetes. So all-cause mortality, your chance of dying is higher for almost everything when you have diabetes, especially untreated diabetes. So it makes sense that maybe some minor small risks with GLP, the overall mortality benefit and morbidity, meaning all cause bad things, not not dying. That's a different scale than somebody who has a BMI of 29 or 30 or 31 or 32 without these other health issues. So we're utilizing GLP in patients who are probably healthier, so we don't have a better understanding of what the risks are for this individual. One of the things that I think I wish we could get more information on is this muscle mass loss.
Yeah.
It's called sarcopenia. And somebody who is entering perimenopause, menopause, if they already have sarcopenia, I'm really concerned about what their health
Yeah.
trajectory is going to be.
Mm-hmm.
So you have people losing weight. There's some studies that show you lose 1 pound of muscle for every 3 pounds of fat.
Yeah.
Wow.
So if you lose,
Way too
let's
much.
say you lose, so if you lose 21 pounds, let's say you're that person, you lose 21 pounds, 14 of it is fat, 7 of it is muscle. Since most people gain weight after they've gone off, so let's say you gain that 21 pounds back. You're not gaining 7 pounds of muscle and 14 pounds of fat. You are gaining 21 pounds of fat. So now you're back where you were to begin with, but you have a lower metabolism because you don't have that lean muscle mass.
Yeah.
Wow.
Mhm. We need more time and more studies to really understand it, I'm sure. But that's
Oh,
very
yeah.
interesting to talk about. Okay, well, we have one final closing question for you. What is one thing that you wish every woman could know about their body?
I love that question. Number one is your body's a temple. Your body is an amazing machine that is incredibly resilient, and it's finite.
Mhm.
And it is one of the only gifts you have that you can give other people. And so if you take care of your body, it is more likely to run better, which just gives you a higher quality of life. Part of that is it's totally under your control. Now, not everything is, but there is an element that if you are going to be healthier, you have to make choices.
Mhm.
There's lots of reasons that might be against you, so to speak. But everybody, I've been practicing for over 27 years. Almost everybody who's walked into my office is fully capable of making choice changes.
Yeah.
And so it's empowering to believe that you have an amazing body. It's empowering to believe you have an element of control. If you have no control, that's the most disempowering thing that I could say to you. It's important to remember that there's two experts in the room. Okay. I have the expertise of understanding your disease, understanding what to ask, understanding what to test, and I have treatment options for you. That's my expertise. Your expertise is your symptoms, your goals and values, and what you will do to change. So, the way those two work together, I have to bring my listening skills with me,
Mm-hmm.
but you have to bring your listening skills, your curiosity skills, and your creative skills together in order for you to have a personalized plan. And that's where you're looking at your optimal health instead of just survival. You want to
Mm-hmm.
thrive, not just survive. So that's kind of a corollary, but the second one you cannot have unless you truly believe that your body is a temple and worth caring for. You have the ability to choose better health every day. And it may look different than yesterday, but there can always be some choice you make that is better than another choice.
Yeah.
Mm-hmm.
Yeah.
Mm-hmm.
I love that. And everyone can do something with that. It doesn't
Oh,
matter.
yeah.
It doesn't matter where you are in life or what your circumstances are. You can always make those tiny little changes and choices that add up in the end to have a really big impact. So I love that message. All
Mm-hmm.
right. Well, thank you so much.
Well,
I love
you
that.
you ladies are amazing, and I am so thankful that you're doing this. This message is really a message of empowerment, and more people need to hear it and see it. So I think this is lovely.
Well, thanks for being a part of it. You have a lot of
Mm-hmm.
knowledge and wisdom to share. So we really, really appreciate it.